Good morning, Dr. Armstrong here. We're going to be looking at Chapter 8 today, the knee, the ankle, and the foot. We'll begin looking at the four bones, the articulations, the ligaments, and the menisci. Just a few comments before we look at the muscles themselves. First of all, know that the tibia is weight-bearing, and then directly onto the talus bone. The knee is a hinge joint. It is diarthrotic or a synovial joint. With the structure and the positioning of the kneecap or the patella or the sesamoid bone, the knee joint is a perfect lever. Note the slide in the PowerPoint. It illustrates a couple slides. It illustrates this idea. In terms of the stability of the knee, I'm sure you're all familiar with the variety of knee injuries that there are, and some of you may have even suffered some knee injuries. The medial and the lateral collateral ligaments help prevent the inward and outward bending of the joint, and the cruciates help prevent the hyperextension of the joint. Note also, and this is really an important point, that the medial meniscus attaches to the medial collateral ligament. So when there's a blow from the outside of the knee, if the MCL goes, so goes the meniscus. Now, just there's slides 12 and 13 on the PowerPoint. I've given you kind of a personal example. I had a few years ago, I ruptured my patellar tendon in an accident at home, and slide 12 shows you the ruptured patellar tendon along with the broken patella and part of the medial condyle showing, and you can see what a mess it is. You can see how the patellar tendon is shredded, and you just may look at that and wonder, how could that ever be repaired? I wish I had more slides than just 12 and 13, but 13 shows you the repaired joint capsule. By the way, this was a great job done by Dr. Corcoran. Some of you may have seen him work, or some of you may have even had some work done by him. I want you to note the shape of the menisci. They're best viewed if you're looking at illustrations looking down onto the tibial plateau. And notice that the medial meniscus is larger, it's C-shaped, and that's so that it accommodates the larger medial condyle. And then the lateral meniscus is O-shaped. Now, an important concept here, especially as it relates to injury, is the Q angle. Now, this is the measurement of the angle between the quads and the patellar tendon. It demonstrates or illustrates the pull angle of the quads. Now, note that women have a larger or greater Q angle than men because the hip bones are wider. This would push the proximal femur more lateral. So this then pushes the knees closer together, and the outside angle of the lateral femur to the lateral tib-fib is more acute, and it makes it that much easier to injure the joint with a blow from the outside. If you look at I have a couple of illustrations in the PowerPoint in regard to that, and you can see in the shaded areas the greater angle for the women, and this results in, unfortunately, the fact that women athletes have a greater predisposition for ACL, MCL injuries than men. Now, a small interlude in the PowerPoint, and if you've been through the PowerPoint, you may wonder why it's there or what the meaning of it is. Basically, I've brought along Jesse Owens here with me, at least his likeness. And in a 10-15 slides, I've given a short discussion from a book called Taboo, Why Black Athletes Dominate Sports and Why We're Afraid to Talk About It. This is a very controversial book. It's been around a while, and it's an interesting book. There are a lot of questions that remain. You end up with more questions after having read it than you do before you read it. Jesse Owens was one of the primary focuses of this question and the issue of the superiority, especially in sprinting, of black athletes during the 30s. Jesse Owens was, if you recall, Jesse Owens in 1936 in the Olympics won 4 gold medals: the long jump, the 100, the 200, and the 4x1. And this was done in Berlin. And in 1936, when Adolf Hitler was in attendance, the story goes that when Jesse Owens was on the stand, that Hitler turned his back. Probably more myth than truth, but the fact is that Jesse Owens did sort of destroy the whole Aryan superiority that Hitler had so built up. Well, a lot of people questioned at the time, why is Jesse Owens so good? And he wasn't the only black athlete that was winning. There were many others at the time, and there were a lot of different conjectures about why they were superior. There were conjectures about on the social aspect, obviously on the physical characteristics. One of the theories that was bandied about had to do with the size of the calcaneus bone, the heel bone. It was suggested that Jesse Owens and all African Americans had a longer heel bone. Well, if you go back to our discussions in Chapter 4 in regard to biomechanics, a longer heel bone would possibly give you more leverage and would give you somewhat of an advantage. Well, Jesse Owens' coach, Larry Snyder, persuaded him to be examined by a physician, and Dr. William Cobb, after giving him a thorough examination, determined that he was anatomically the same as any other white sprinter, and he added that the theories that were out there about the different characteristics were, as he called them, pseudo-scientific conjecture. There's another interesting fact. If it's kind of like fast forward, and if we were to consider the superiority in distance running of not just Kenyan runners, but the Kalenjin tribe of Kenyan runners. Now, the Kalenjin tribe number about 3 million, or about 45 thousandths of a percent of the Earth's population. Well, the fact is, the Kalenjin tribe of Kenya literally dominates the distance scene in the world. Now, they're not the only strong distance runners, but as a whole, they tend to dominate. So how do you explain their dominance in the distance community? Is it diet? Is it the fact that they walk or run everywhere because they don't have cars? Is it a socioeconomic thing? Well, to date, there's no identification of a running gene, nor is there conclusive evidence of sufficient cultural or social influence that can really explain this athletic superiority. Author John Entine of this book would have you believe that there's enough evidence to suggest genetic differences. Well, I would leave that with you right there. There is no, like I say, evidence to prove that there is a running gene, but yet there's something which is, there has to be some explanation, and to date we don't know what that is, but it is an interesting discussion nonetheless. All right, back to the muscles of the knee and lower leg. let's talk about the vasti muscles first. Now we talked about the rectus femoris in the last chapter because it crossed two joints, and it was active in flexing the hip. Well, we add the other three quad muscles to this because they are active in extension of the knee, the vasti. First of all, we have the vastus lateralis, and this one is most active during the last half of knee extension. So if you're on the knee extension machine, about halfway through to the last half of your range of motion of that exercise, the lateralis is most active. The vastus intermedius is the one that sits underneath the rectus femoris, and it's not palpable. And then the medialis, this one is the most active of the vasti through the full range of motion. We have the gastrocnemius. Now the gastroc is the strongest of the calf muscles. It's a plantar flexor as well as a knee extensor. Here's another example of a muscle that crosses two joints, and that when it's performing one action, it's not as effective in the other. So if you are plantar flexing, fully plantar flexing, and then you try to bend your knee, it's not that you can't do it, but you have to rely on more of the hamstrings to bend the knee. Or if you have your knee bent and then try to plantar flex, it's more difficult at that point. The gastroc is the most superficial of the two calf muscles. It's easily palpated, it's easily identifiable. The distal attachment is the Achilles tendon. And you'll notice that the two heads of the two proximal heads of the gastroc, how they sort of fan off, and in a very well-developed calf, you can see this, and you can you can not look at the fibers as such, but you can get an idea as to how effective the construction of the gastroc is. The soleus is the calf muscle that sits underneath the gastroc. Now you can palpate the soleus primarily if you plantar flex and feel laterally on the outside of the calf, on the outside of the gastroc. You'll be able to usually palpate the soleus. Now the soleus is a typical plantar flexor, meaning that's its only job. The popliteus is a knee flexor. It also is active in some medial rotation because of the distal attachment on the posterior side of the tibia. If you'll notice in the text, the illustration of the popliteus, it's a very short muscle. It goes from the distal femur on one side to the proximal tibia on the other side, and it's a good example of how when a muscle contracts from the middle to both ends equally, how the proximal end is going to be the one that's stationary, and it's going to, as it bends the knee, it's going to bend the lower leg. The tibialis posterior, this is the deepest posterior muscle of the calf. It plantar flexes the foot. And any of you who have ever suffered from shin splints, it's interesting to note that most shin splints come as a result of detachment of fiber from the bone of the tibialis posterior. But treatment of shin splints a lot of times has to do with working the tibialis anterior. Now this particular muscle is in the front of the lower leg. It's a dorsiflexor. It points the toe up, and it can be palpated laterally along the shin when the foot is dorsiflexed. Now, we talked, I would bring you back to a discussion we had in regard to biomechanics when we talked about dorsiflexion and running, and I talked about just briefly about a device that some have used in sprinting to keep the foot dorsiflexed through the entire phase of the running motion. And this particular muscle, the tibialis anterior, is the one that is most active in this particular movement. If you've ever gone rollerblading or roller skating or ice skating, where your feet are sort of fixed in a dorsiflexed position, you'll find that muscle really tires out quickly. Now, I mentioned a minute ago that the treatment of shin splints often comes with the use or the action of the tibialis anterior. One of the things that you can do for shin splints is to, for instance, sit on a table where your legs are hanging over and to dorsiflex the feet quickly, constantly for maybe about 5 minutes if you can do it that long, and do it multiple times a day. And if you can actually make it weight bearing, maybe tie a towel around some books or something and you hang that on your toes and then dorsiflex. Interestingly enough, this particular exercise has been known to help some people get over shin splints. We talked also about the gracilis in the last chapter, and that's because it's active as a hip flexor, but it's also in this chapter because it's a knee flexor as well. And you'll recall that the gracilis is the dorsal tendon of the gracilis. It attaches to the medial side of the condyle of the tibia, and if you palpate, if you have your leg fixed on the floor, your foot on the floor, and then you contract the knee, you are sort of bending the knee, but your foot remains on the floor, and then you try to palpate medially, that tendon, the first tendon you come across, the one that is most medial, is the gracilis. We talked some about the hamstrings in the last chapter because they are active as hip extensors, but they're also in this chapter because they are knee flexors. A few other considerations I want you to be aware of as you study this chapter in the PowerPoints. And by the way, there are two PowerPoints that go along with this particular chapter. One deals specifically with the knee, and then the others deal with the foot and the ankle. Note on slide 73 of the PowerPoint a discussion on genu varum of the knee. And in particular, what I want you to see is how as the menisci tend to wear down, and the menisci of the knee will wear down based on age, based on activity, disease, injury, but as they wear down, there tends to be less space between the bones at the tibial plateau, and that you'll see what will happen then as especially you lose space between the medial at the medial condyle, you begin to see the legs bow outward. So as you look especially at elderly men as they walk, a lot of times you'll see that they're extremely bow-legged, and most of the time that's due to the wearing out of the medial meniscus, and if you were to take a X-ray of that, you'd show almost zero space between the bones. Note that I've added a PowerPoint to your list, and it's called ACL Surgery Update. Now, this was put together by Dr. Ellis from Oak, and about 4 years ago he came to my class and showed this PowerPoint. It is 4 years old, but it's still very relevant, and it shows a lot of the things that are done during ACL surgery. Some of the changes that you'll see, however, in surgery is the varied use of the tendon tissue. I mentioned in the last video that it started out, doctors were using more of the patellar tendon to replace the ACL. Now they use more, in addition, will use tendon tissue from the gracilis or the semitendinosus or membranosus. And finally, again, I'm mentioning that there is a second PowerPoint for Chapter 8 on the ankle and the foot. Thank you very much, and hope you have a good day and a good weekend. See you again.